Great. Welcome back, everyone, to the House Healthcare Committee. It is Wednesday afternoon. And today we have Department of Mental Health back with us to focus specifically on youth. We had talked earlier with Department of Mental Health, and we never seem to get to the youth section. So this is great. We appreciate you coming back specifically on that. And then afterwards, we'll be hearing from the Brattleboro Retreat, which obviously plays a key role in our mental health system of care in Vermont. So I think what we'll do is some introductions, since it's the first time here, and then we'll turn it over to you for introductions. So I'm going to start with Topper.
Topper McFawn, representative from Barrytown, represent Barrytown Blues.
And Lori Houghton, City of Essex Junction.
Alyssa Black, Town of Essex.
Ryan Sheena Burlington.
Alan DeMar, Enosburg, Montgomery.
Joe Andriano, I represent Orwell. I live in Orwell. I also represent Shoreham, Whiting, Sudbury, and Hubbardton.
Art Peterson, I represent Clarendon, Wallingford, West Rutland, and a piece of Rutland Town.
Leslie Golden, Wyndham 3, Rockingham, Westminster, and Brookline, Bells Falls area.
And then we have someone on the screen, Daisy.
Daisy Berbecco, representing Winooski.
Great, thanks, Daisy. And Daisy, we can see you, so just raise your hand or text me if you have any questions. We're pretty formal. I've made it pretty formal. We go by first names, but whatever is appropriate for you. But if you want to get started, that'd be great.
Great, thank you. Thank you for having us this afternoon. My name is Laurel Omland. I'm the director of the Child Adolescent Family Unit at the Department of Mental Health.
I'm Dr. Haley McGowan. I'm a child and adolescent psychiatrist. I'm the children's medical director for the Department of Mental Health, which is half of my job. And the other half, I'm the director of acute care child psychiatry at UVM Medical Center. So all the kids on the medical floors and in the emergency room.
Great. I think I've been on a couple of tours with you maybe at some point. So the name sounds familiar. Great. Let's get started.
Great. So we wanted to do an overview of the system of care, given that you have heard from Commissioner Hawes and Deputy Commissioner Crumpf about the general structure of our mental health system. So we're going to dive a little bit more into what are the child, youth, and family specific aspects, as well as some of the initiatives that we've been working on. And then, of course, always glad to answer questions as we go. So this first slide is it's a little bit of a history. I'm not going to go into it in detail, but it is just to represent. There used to be a ward in the state hospital that was closed in the early 80s. There was a large federal focus around improving and creating systems of care for children, youth, and families across the country. Vermont was awarded one of the early system of care grants. And then the legislature with a lot of involvement of families, providers, and others, also drafted legislation that was called Act 264, which passed in 1988. And that really set a foundation for how our system functions, how we partner together with our other child serving entities. At that time, it was SRS, but Child Welfare, Juvenile Justice, Department for Children and Families, the Agency of Education department back then, families, providers, et cetera. And Act 264, I'll get into a little bit later, but as I said, that's an important aspect to hear. You'll hear people reference it, and some people don't know what it means. It established our system of care for children and really set forth some expectations for how we work. And then related to that, I think innovative in Vermont at the time, and in the country at the time actually, was the creation of Success Beyond 6, which again was legislatively authorized for how we could provide school mental health through the Department of Mental Health's Medicaid, but really leveraging partnerships at the local level with school districts. I'll talk more about that later too, because I think that was an area of interest. So Act 264, briefly, this is what it covers. There is a link in there if you want more information, including the original act. But it really did establish an expectation that human services and public education work together on behalf of children and their families, and to coordinate services for them so that things weren't happening in silos, but there was intentional coordination around what are the needs and the gaps and how are we going to address those for families. It develops these things that you see here. So we have a structured process for how to coordinate those services into a plan. We have one local interagency team in each of the state's 12 districts of AHS. We have a state level interagency team that those different entities are part of, meaning Department of Mental Health, Department for Children and Families, Agency of Education. It's been expanded, which I'll talk a little bit. We have a governor appointed advisory board, the Act 264 board. And then there is a very strong component within all of this that family input, parent involvement is a key piece of this. So the board has representatives of at least a third family members who have children who have experienced our system of care.
So what is the board called?
The Act 264.
Never heard of this. Okay, great.
In 2005, this was expanded. So this really started to meet the needs of children with severe emotional disturbance, and it established a definition of who met that criteria. This definition is slightly different than the federal definition. It's a little bit broader so that we can make sure we're connecting with those families who have broad needs. In 2005, that was expanded to cover all disabilities under special education. So it's not just now about children with SED, but other disabilities under special education. So that brought others to the table for those local interagency teams, as well as the state interagency team. So we have Hireability, formerly Voc Rehab. We have Developmental Disability Services out of Dale, et cetera. So that's just another aspect that I thought it would be helpful for this committee to understand. Next slide, please. The next is a federal mandate. EPSDT is how we talk about it, but that means early periodic screening, diagnostic, and treatment. This is a Medicaid mandate nationally for ensuring that the right services are provided to children under the age of 21. And so that really does guide our actions as a department, as well as other departments who are providing Medicaid covered services to children and youth. And does drive some of the rationale for why we have to look, strengthen our own system here in Vermont, but also perhaps leverage some from out of state as well. Next slide, thanks. And then I thought it would be helpful just to say who we are at the Department of Mental Health. So this is our child, adolescent, family unit. We have the director, myself, we have our medical director, Dr. McGowan. We have an operations chief who oversees our 3 children's care managers. Those care managers are who provide supports to our designated and special service agencies and others to help navigate the system and different levels of care. We have a school mental health coordinator who also is involved in a Project Aware grant, which I'll speak about in partnership with the Agency of Education, an admin assistant, and then some grant managers.
Can I ask a quick question on the school mental health coordinator? Do they coordinate the work that the DAs do in the school, or just specific to what's happening with Department of Mental Health?
So it's at the state level.
Okay.
One of her primary roles is to connect with those designated agencies, school mental health providers, directors. She oversees the financial agreements between the department and them to allow that Success Man 6 Medicaid to go. I'll get into that a little bit more.
Great, thank you.
Essentially, we have 10 individuals. It's 8.5 FTEs. We did get recent approval to have a 4th care manager to focus on our home and community-based services activities that we have coming ahead of us. Next. So again, wanted to just lay out how we think about the work. We have a vision that all children and families are emotionally healthy in Vermont. We do try to really think about that from the public health model. What do all children and families need? What do those who have developing needs or at risk need? And then what do those who have identified needs? And so that's what you can see here is how do we promote wellness for everybody? How do we think about early intervention, identification services and activities? And then what are those more intensive supports and direct interventions that we need? So I wanted to highlight that. And then the next slide shows a little bit of how that looks when we think about our mental health system of care within all of that. And so again, I don't need to go into the details. This is here for you, but when we think about promotion and prevention, we have some activities related to that. We've really tried to partner with those who have a strong focus on promotion and prevention, like the Department of Health, Maternal Child Health folks. And how do we, this is really about how do we get kind of basic information out to children and families, as well as those who are serving children and families about how do we support a healthy environment and healthy families in general. And then with the next level, we do have different levels of care, which I think were covered with you previously, community-based and all the way up through more intensive levels of care. And that's what is highlighted in those next layers there.
Leslie? I'm just wondering if you could give examples of the
Sure.
work, so that I can
Sure.
understand what people are doing when they go to work that day.
At Department of Mental Health or?
Yeah, and intersecting with schools and
Yep.
DAs, and maybe this isn't the right time, but I'm just trying to picture.
I will keep that in mind as we talk about some of these initiatives, because I did want to get this. I'm just trying to say, like, how do we think about our work and where do we plug things into it? So we do oversee different grants and contracts. For example, we have a partnership with an entity that called Puppets in Education out of the Vermont Family Network, and they provide some social emotional promotion within school settings. So that's one example of an early promotion activity. And then others are about how do we engage with the designated agencies around particular situations with families, or to improve their services, to bring evidence-based practice training opportunities to them. And again, I'll get into a little bit of that. Next slide. This is just some basic data about children and youth served through our public designated agency and specialized service agency system. So you can see up in the top left is the general trend over many years, and then zooming in a little bit more on recent years with some dips that are in there. This, I would say, is influenced by availability of workforce, as well as the level of need. So it's hard to kind of make some quick assumptions about why those fluctuations, but if we think about those components, that's a piece of it.
If I could, what's the denominator of children?
So the numbers represented here are those who have been served.
Yeah.
The
So what
broad
number-
denominator is the
Yeah, how many children?
how many children are in the state?
Yeah, like what percent of children are being served? Sorry, I don't.
No, that's a good question. I should know that off the top of my head because I've had to put it in grant proposals. I apologize. I'm going to say it's over 100.
Half, or you're serving 10%, just to get
Yeah.
a sense of it.
That's it. I apologize that I don't have that.
I don't, I'm sorry to put you
top
on
of my
that. It just was like, well.
So this slide was really just to provide a very high level snapshot of some of the areas of our current focus. We will get into some of these, and it's really difficult to talk in depth about all of these in the time that we have today. The highlighted ones are the ones that I'll focus on a little bit more today, and glad to come back at some point if there's.
Thank you.
So the first one that I want to talk about is, and it's our Pediatric Mental Health Care Access Program. This is a federally funded grant program that just started last October. So we've finished our first year of this. It was awarded through the Health Resources Services Administration to us at DMH, but we partner very closely with the Maternal Child Health Division of Department of Health, as well as in FQHC, the community health centers out of the Chittenden County region, and the Vermont Child Health Improvement Program, or BCHIP, you might know it as, out of University of Vermont. We also have a non-federal match that comes, that was required as part of this funding, and that comes through a private foundation grant to the community health centers. The intent of this was really to expand access to mental health supports for children by improving the quality of care through primary care clinicians. And we'll get into more detail of that. It really is about this child psychiatry access program that has been stood up, as well as providing training educational opportunities for not just primary healthcare providers serving children and youth, but also the mental health providers that they would be referring to. So that's an exciting aspect that we have going. And before I pass it on to Dr. McGowan to talk more about this, one reason we really wanted to pursue this funding opportunity is because, as you know, access to child psychiatry across the country has been pretty challenging as well in Vermont, although we do have some great fellowship development programs coming out of UVM for that. But this is a way to make sure that we've got the child psychiatrists that we do have are providing services to kids who truly need that level of support, and that we can provide consultation and other supports to children who might otherwise be on waiting lists to access psychiatry. But again, I'm going to defer to you.
Next slide, please. So the Child Psychiatry Access Program was funded. It's funded through a DMH grant, as Laurel mentioned, a private foundation matching grant. These are both time limited, so we're a year and change into a 5-year grant cycle. The Vermont CPAP, as we call it, launched in June of last year, so June of 2022. As Laurel mentioned, it's hosted by the community health centers with some staffing from UVM Medical Center, the Vermont Center for Children, Youth and Families, sort of their outpatient child division. And I'd be remiss not to mention the medical director, who's Dr. Greta Spotswood, a colleague of mine, also a child psychiatrist based at community health centers. She deserves immense credit for getting this off the ground quickly and efficiently. And her vision, which became our vision, really came to life with pretty stunning efficiency over the past year. The CPAP provides consultative services for Vermont primary care providers who have questions about diagnosis and treatment planning for children and adolescents all the way up to age 21. So research has shown that nearly half of all youth will meet criteria at some point for a mental health disorder, either in childhood or adolescence, and about 20 to 25% of them will have a mental health disorder, which will result in severe impairment or distress. And so, as you might guess, limited, and as Laurel mentioned, limited access to mental health resources here in Vermont means that primary care providers, pediatricians, family medicine doctors end up providing that care, often in ways that feels far out of their own expertise and training. So what Vermont CPAP does is support primary care providers statewide in efficiently diagnosing and treating mild to moderate mental health issues within the primary care setting through telephone consultation with child psychiatry service and through care coordination. So what that actually looks like is it's a phone line that is staffed every day of the week, like business hours. And each day there is a child psychiatrist fully assigned, that is their whole job that day, to answering that phone. The calls are triaged. The calls come in from primary care providers in the community. They're triaged by liaison coordinators, who are sort of mental health social workers that are, experts really in Vermont's system of care and what resources are available. They are triaged at that point. Sometimes it's just treatment planning and doesn't need to go to the child psychiatry for consultation, but typically it does go to child psychiatry telephone consult. And that day, sometimes within 20 minutes, they have a child psychiatrist on the line to answer their questions. Once in a while, it's when the kiddo is actually in the office, but usually it's sometime that day they find a time that works for both the provider and the child psychiatrist. And at that point, they make recommendations. Sometimes it's about medication management, sometimes about diagnostic clarity, sometimes it's treatment planning, what screener should I be using, that sort of thing. And then it usually is wrapped up by that liaison coordinator who helps connect to resources in the community. And as Laurel mentioned, so this really does help to sort of save a lot of that child psychiatry workforce for those more acute cases. And prevents all of those children who they are consulting on ending up on wait lists for child psychiatry or more specialized services that could, with support, be answered by a primary care provider. Next slide. So there's some really compelling statistics so far. As you can see, let me put the slide so you can see it at the same time. There we go. So this is registered practices by clinic type, that pie graph on the left. At the top, it notes 79 clinics. This was in December. It's grown since then, have enrolled in Vermont CPAP, and 387 individual providers. You can see how it breaks down on the left there, and then the age of patient focus of consultation. And then another important statistic or worthwhile statistic to mention is that as of the end of this year, 29 out of 33 pediatric practices in Vermont had enrolled.
Wow.
And it's actually higher now. There's only a few that haven't in the whole state of pediatric practices that haven't yet enrolled. And that is one of our goals right now, is figuring out how to get every single practice enrolled. It's quite a few naturopathic practices as well as family medicine practices. And so the goal now, pediatrics was sort of the initial push, and now the goal is to how to figure out how to get everybody sort of into that fold, anyone who sees kids and could benefit from this sort of resource.
I'm just going to comment too on the age of the children, 50% are 13 to 18.
Yes.
Yep.
And Art has a question.
Yeah, I'm very interested in this because, let me go back though and ask a question. How do folks find out about your service? That's probably my first question.
Sure, and you can help answer this.
I know I think you mentioned that referrals.
I think the key is that it's for providers, the primary care provider, to make the call. It's not direct for the families.
Okay.
So we're promoting it to the practices, and that's where our partnership with Vermont Child Health Improvement Program, they already have a relationship with practices, so they're helping do that outreach to talk to them about this and make that link.
Okay, so if a parent feels that they've got a family problem, that this might help, do they know about it, or you don't encourage them to call, or how does that work?
I would say that the goal is for the medical home to know intimately what is offered through the service. And then they know these families so well that when that problem inevitably comes to the surface in a primary care setting, or they call in crisis to their primary care provider because that's their only point of contact, the primary care provider is, knows immediately like, oh, I have this line, I have this resource, I can call and get some help.
How about schools? Do they have any similar access that way?
Not yet.
Not yet. We know that some other states have really grown their programs to be
Yeah.
able to provide consultation to school personnel as well. We don't have the staffing yet
Well,
to cover that.
the only reason I mention it is this might be a way to keep kids out of the emergency room. That's why I'm kind of quizzing you on it, because anything like this might prevent a parent from bringing a child in who really doesn't need to be in there, that you can solve the problem or start the conversation about solving the problem and keep them out of the very costly thing.
Agreed.
Have you seen, I don't know, maybe this just started, I don't know, have you seen any improvement in that?
It's interesting you ask. We had hoped to be able to see, could we look to the use of emergency departments for mental health concerns as a metric of the impact of this? And
Yeah.
it's hard to draw those direct lines to it.
Yeah, it is.
It's something we track, of course. And I think I would say that this is one aspect of many ways that we're trying to get at how to address that concern, because, having some mobile crisis supports could also be supportive to the
Right,
family. Families knowing they can call 988, or what are those other avenues that they can pursue instead of having to go to an ED?
Well, I don't want to monopolize, but I have one more question. So a child's in the ED for whatever reason. Can this be used from there to give him or her some support while they're in there?
So at this point, I can answer that. I'm working the ED at UVM.
Okay.
And so we have child psychiatry in the emergency room at UVM. And so what we are often doing is calling their primary care provider directly. We speak to every primary care provider when a kiddo comes through and making sure that they are enrolled for the Vermont CPAP line, because these kids often, especially if they're discharging from the emergency room, are going back to their primary care. We're setting up those appointments to connect with their medical home and saying, if you need support beyond what we can provide on the phone right here in the emergency room, then, here's a resource. I think it's something that we're working on in other emergency departments statewide that do not have the resource of child psychiatry, is making sure that people are aware that that they should be providing this resource to anyone who is sending a kid back to their PCP.
All right, thank you.
We have a couple more questions, Brian and then Joe.
Do you hear from parents and children that cost is ever a barrier to, accessing this through their primary care provider?
We haven't heard that. I mean, this is a free, because it's grant funded currently, consultation service to the primary care.
Yeah, I guess what I was thinking more is are they unable to afford to go to their primary care provider to access this? But if you may not be hearing about it because they may not be going.
Yeah.
So
I don't, and it's 6-7 months in being established, so I think it's still early.
maybe that, and so maybe it's something just to look out for, because I'm wondering too, in the emergency room, how often people hear, when it's recommended that they follow up with the primary care, how often does crisis or the other staff hear, I can't, we can't do that because of the cost, so.
It's about,
Yeah. Joe?
My question is very similar to Brian's, but a slightly different spin on it. I'm just curious, do we have statistics about, how many children in Vermont are having regular well-check visits and have that sort of ongoing relationship with the primary care provider? Because obviously they would need that ongoing relationship to funnel into this program.
yes. Those statistics or data exist. That would be primarily through Maternal and Child Health Division, but that's something that, again, because of our partnership here, is an area of interest. I know they've definitely had an initiative to increase children who have an identified medical home. And then looking at access to that is an important aspect.
Just have a follow-up question. So this was a HRSA grant, so I would expect that there's a lot of quality metrics and data that has to be collected through the process. And is that at checkpoints throughout the term of the contract? And is that something that as they arise could be shared with our committee?
Certainly. I mean, I think I can bring that back to the team. We do have an evaluator on the project, and we have, she does monthly reporting to us about the use of the child psychiatrist.
And we don't need it that much, but it would just be nice, maybe at the start of each legislative year, it would be helpful to see where this is going. And in my head, I'm thinking we'll have Blueprint in, and I know there was just the report to do some more integration between mental health and primary care. So it'd be interesting to see how this all, layers on top of each other to ensure we're getting the children they care. So we'll keep that in our, and I don't know if you have any comments to that, the Blueprint piece or.
Thank you. Only that we have had some initial conversations with the Blueprint director about what this is and that we're going to be looking at, the success of it in the long term and how could that be considered.
Right. Good. And my one last question. The consultation between the provider and the psychiatrist. The psychiatrist is based at Community Health Center or at UVM?
It depends. There's 5 different psychiatrists that staff it, and they are not all employed by one entity. They are just all contracted into the grant.
Okay.
And so they are wherever they are.
And are they getting paid for this work?
Yeah. Yes.
Through the grant. Okay.
Yep.
Great. Thank you.
Daisy has her hand up.
Oh, I'm sorry. Thank you, Daisy.
Thank you, Art. Thanks, Lori. I've heard such wonderful things about this project, and I'm glad to hear you speak about it directly. I wonder if we want to learn more, if you'd be willing to share a link to the HRSA grant RFP, and if you could share your response to it, that might be a nice way to kind of learn the foundational goals of it.
Certainly. There is also a link in the slides to the Vermont Child Psychiatry Access Program, which has some information in there specific to that program, not the broader grant. But we can follow up with that.
Great, that'd be.
Thank you.
So relatedly, and longer in place is another HRSA-funded project called STAMP, or Screening, Treatment, and Access for Mothers and Perinatal Partners. This is a little bit of a flip where this the federal funding is going to Department of Health, Maternal and Child Health, with DMH in partnership with them. And the focus of this is to address pregnant postpartum women and their children and families, and really providing a variety of supports and services to them. In here, there is some support for expanding the Help Me Grow resource database that people can call through 211. There's information in there about support specific for women and families, their partners who are experiencing perinatal mood and anxiety disorder type of concerns, or just general parenting questions as they're entering that phase. There has been quite a bit of training for providers, both on the medical side as well as the mental health side, to understand how to screen for concerns and what types of interventions are most effective. And there is also a psychiatric consultation line through this as well, with an adult psychiatrist who can provide consultation to primary care, OB, other types of providers who are working with the family, often the woman in this situation, to provide psychiatric consultation to them around diagnoses of perinatal mood and anxiety disorders, treatment options, medications, what can and can't be used during pregnancy and lactation periods, et cetera. So that's something that we have also been having conversations across these 2 projects about, we have 2 psychiatric consultation lines, where do we go from here? So we're looking into efficiencies and sharing some approaches to that.
I know we're specifically talking about children here, but I'm just curious, to the best of your knowledge, is there any sort of similar program for adults in the state?
I think the only thing I could speak to is Vermont Program for Quality Improvement in Healthcare has a new initiative around providing psychiatric consultation to emergency departments.
Okay, great. Thank you.
And that's across the age span.
And we did have them come in. That's the telepsych program we heard about.
Thank you.
Okay.
Okay, I'm sorry. How long, so this is a grant that has a timeline on it?
Yes, this one is expiring in September.
Okay.
We anticipate a new notice of funding opportunity coming out from HRSA
Great.
soon.
Okay.
And all of us are interested in reapplying.
Great.
I'm just wondering about numbers of this has been in existence for a while, the child one is new.
Mhm.
Do you have numbers of consultations done?
I did not put them in here. Yes, there are numbers for that. I would say with this STAMP program, the psychiatric consultation is a part of a broader range of activities that are happening. And I think that my understanding from some recent conversations is it's not called as frequently as our new child psychiatry line is at this point. But it still is used and it's still a value for those providers who have been tapping into it. Okay, school mental health. I think this is an area that I've talked with other legislative bodies before because Success Beyond 6 and how this works is complicated. So I thought I would talk a little bit about it. So what is it? This is how it's a Medicaid program for school-based mental health using Department of Mental Health's Medicaid authority to provide those school mental health services through our designated agencies. And they have a local agreement and partnership with, sometimes it's at the school level, sometimes it's at the district or supervisory union level for what those services are. So it really starts there. It starts at the local level where a school or district identifies a need around mental health within their system and reaches out and connects with, or, you know, the designated agencies also outreach to let schools know what they can offer. But it's driven by the educational entity saying, here's what our needs are. There's an agreement that is in place there. Some of what is being asked to be provided by the designated agencies is a Medicaid covered service and provided to Medicaid enrolled students. And so that's what can be covered by Success Beyond 6. If there are other activities that don't fall into that, that's just that local agreement. So essentially there is a local contract and the school or district provides local match. They provide, we call it clean, but non-federal funding to the designated agency, who then passes that up to the state to be able to, they draw down Medicaid through our system, and it's that local dollars that supports the drawdown of the federal Medicaid for Success Beyond 6. So this does not come out of the Department of Mental Health budget, but it is our Medicaid authority, if that makes sense.
It does. I have a couple of questions, if you know, and we've talked about this before. So, and I appreciate you putting it in here. And actually, you know what? I'm going to let you finish. Okay. And then I'll ask questions if there's.
Okay. There is a link in here to a legislative report from 2020 that goes into some of that detail and specifics for some of the programs, if you're interested. But high level, next slide, please. Sorry. What is included under Success Beyond 6? So again, this is Medicaid covered services for Medicaid enrolled students based on local partnerships between the schools and the designated agencies. Those agreements are in place in nearly every school district, about 82%. There's been a little bit of fluctuation, I would say, in the past couple of years. There are different reasons or contributing factors to that. I would say between workforce challenges that the designated agencies have experienced in fulfilling some of those, as well as federal dollars for COVID relief, ESSER dollars flowing to schools and being able to meet some of their needs through those. So what's covered under Success Beyond 6, if we could think about it as kind of three buckets of services, one being school-based clinicians. And those clinicians are in a particular school, or they might be, you know, split across a couple of schools, depending on what the district's interested in. And they can provide direct intervention supports to students who have identified mental health needs. They can also, because this is funded through a monthly case rate, There's a little bit of room in there because of how we designed this alternative payment model to be able to provide other support consultation to the school that's not just driven by a fee-for-service approach of seeing a student.
So I just want to make sure everyone understands that. So you're paying one set fee, one set payment
If they meet a minimum service level threshold and a minimum target of students that they provide direct service to.
which gives them some flexibility on how the money is used versus I'm seeing this person, I'm going to charge this for that
Correct.
amount. Yeah.
When you say them, do you mean the designated agency, the schools?
Designated agencies.
Okay.
Go ahead. I'm curious about the 82% number. Why not 100%? What's the barrier to entry?
Again, this is driven at the local level, and so I think it's about local relationships, what schools or districts already have in place. And as I said before, that number actually went down slightly. And I do think that some of the federal COVID relief has given schools other ways of trying to get at some of those needs.
Let's let her finish the slide and then we'll come back for questions.
So school-based clinicians being one, behavioral intervention programs is another that you might have heard of. This is where there's a more intensive level of support to a particular student within a school setting. And so we have a behavioral interventionist, and then a part of the program is also a board-certified behavioral analyst who really tries to understand what are the behaviors that are of concern within the school, why they're reaching out for this. Typically, these are students who receive special education supports. And they develop a behavioral support plan that is carried out by the behavioral interventionist. There's a lot of data tracking of improvements, et cetera. This is still a fee-for-service Medicaid program. And then lastly, we have several therapeutic independent schools that fall under this concurrent education rehabilitation treatment category, CERT. These are schools that you might have heard of, like the Baird School, the Gene Garvin School in Chittenden County, the Washington County Choice Programs, Laraway School, and a program out of the Claremont and Orange County region called East Valley Academy. And those have it's a blend. They're Agency of Education approved independent schools with a rate set for the education component, and then this therapeutic component under Medicaid for the therapeutic activities that happen there. These are run through our designated mental health agencies. That's what differentiates them from other independent schools. And I was going to say something else and I lost it. Sorry.
No worries.
And then I wanted to give a nod to some reform work that we have been focused on over the last several years. It has evolved with the impacts of COVID and where our focus has been. But this is work that we're doing with Agency of Education. We do have Department of Vermont Health Access payment reform folks at the table, and then representatives from the local mental health and school or districts to really think about school mental health in general. How can we look at equity of access areas of concern? You know, as you pointed out, that the provision of Success Beyond 6 school mental health Medicaid is driven by those local decisions, but we want all students to have access to effective mental health supports. And that doesn't have to be through this mechanism, but it needs to be in place somehow. And so there have been lots of discussions about how do we get at that? What is the ultimate goal? Because there is local choice, local decision-making by school districts. So that's been an area of continued work. We have done some review of what are the different funding options that are in place through federal and state resources through education as well as mental health that support social emotional mental health activities in schools, and it's quite varied, and the eligibility criteria for those different funding streams are varied. So we tried to get very solid on that so that we can communicate that more clearly to each other, as well as to the local parties. And we also have been looking at data and what measures do we each respectively collect, and how do we know what student need is and how students are doing and what's reported up to the state and what's not, to try to be able to get at some of that. So that's continued work that we're in the middle of.
And so is that work that will eventually be provided in a format that we could understand maybe what policy recommendations might be needed or work that you all will be doing? Do you have a timeline on this work?
I can't say that we have a timeline. It is systemic work, which it's hard to make an estimate on. We do have a summary report about where we've been.
Okay.
And I would say that this action, this commitment to looking at all of this really came out of that prior 2020 legislative report where we put recommendations forward about what needed to happen in this arena. And so this was kind of taking those forward.
Let's do a couple questions, Art and then Leslie.
Yes, just a couple of things. I want to try to understand the mental health stuff here. Known mental health issues that a student has, where does that come from? Where does that start? In terms of known by whom and who starts that?
That is a great question and starting point. And I think it's an area that we are doing some focused work on in different ways. Project Aware, which is something I'll also get to, is talking about that also. So how is that even identified that a student has concerns?
Yeah.
It can happen in different ways. Students' behavior in school is an obvious attention, right?
But let's stop there.
Yep.
What distinguishes between behavior and mental health? And, you know, where you have a parent, a child, and you have these indices that indicate things. And I always try to put them together and say that child just needs a little more discipline versus you really have a mental health issue. And I wonder, and the parent has to be involved at all. So anyway,
Yep.
sorry.
No, it's you're spot on. Behavior often is just kind of the outward expression of perhaps what someone's struggling with. And so I think that's why it's important that anyone in any role might be able to pick up on some of that and make some of those initial connections. And I think ultimately there might be some situations where it does need further assessment to determine, is there an underlying mental health concern here? Or is this something that could be addressed through some additional supports and planning around the behaviors, right? So that could start from a school counselor, guidance counselor is what they were called in my day, but school counselors. It could start with a school nurse. It could start with a principal, a teacher. It could start with a parent. And parents often reach out to their teacher or their school counselor. Where there is a embedded clinician, like these school-based clinicians, they can also be a point of, we're trying to have this approach of, let me back up. Agency of Education has established this multi-tiered systems of supports framework, which is really about how to understand the needs of all students. Same thing, public health approach, right? Those who are at risk and those who have identified need. And that can apply to academics, or it can apply to social, emotional, behavioral needs. And so within the social, emotional, behavioral component of MTSS is the acronym that they use, there are different ways of getting at that. Positive behavior intervention and supports is one of those. And that really is about training all school staff around understanding behaviors and how do you approach things in demonstrating, what are the positive behaviors we want to see here? How do you respond when a student isn't necessarily following those? Using positive interventions instead of more punitive, punishing, or et cetera, types of responses, because we know that's more effective, the positive interventions. So within all of that, what we're trying to do is make sure that schools have protocols so that when there is an identified need, what do they do? Who do they go to? What's that next step in process? If there's a need for further assessment, a family, of course, needs to be a part of that. I also need to be cautious to say I'm not an education leader or policy person.
Right.
So
Okay. No,
I'm on the mental health
I
realm.
understand that, and I appreciate you saying it. Does this go on a student's record of some kind, or health record? Okay, a student does something stupid in school, and they're counseled. Does that go?
So I think these questions are probably more geared towards the schools, not Department of Health. So let's hold those and we'll get some answers for you. Leslie?
So last year we did a really big workforce bill, and one of the things we heard was that people were leaving designated agencies because of the pay was so low to go to schools, to be hired by schools to do that work in schools, and almost cut out the middle people. So I'm just wondering what your thinking is about that as you're doing your reform work. Is that part of the thinking? Do the designated agents, are they required? I mean, what purpose do they serve in a way is what I'm asking, and could it be streamlined in a way to be equally or better, more effective?
Great questions. So I do think that there's, as I said before, schools and districts have choice, right? They're autonomous entities. They can make decisions about who they partner with, who they bring in to meet the needs within their buildings. I think there is some benefit to having some approach where it's not just one individual who's responsible for providing the school mental health services, but that they have access to clinical supervision and training, and really understand how does that activity fit within this multi-tiered system of supports. I think the ultimate goal is that students have access, right? And so how that occurs, we just want to make sure that it's using good practices, it's part of the system, and it connects with the external supports and services that it can connect to. So if that can be through designated agencies, and that's what schools are seeking, great. If that's a different process and it's having similar outcomes, great. But I think schools, that's part of the role that they and districts have, is to take a look at that and what's the effectiveness of it.
And I want us to watch the time here because I want to make sure we get through this presentation and give Brattleboro Retreat enough time too. So let's move on. Go ahead, Daisy.
Laurel, I just wonder if you have anything to say around the fact that the Building Safer Communities Act had a significant section around supporting access to healthcare services in school, and also went around promoting access to mental health in schools. Did DMH or AHS do anything to look at improving telehealth or telehealth billing for school mental health services? Or are we looking at any grants that might have been available through that act?
I believe that the school mental health specific focus aspects of that were targeted to the state education authority. So that's not something that DMH could have pursued, but we are partners with Agency of Education and are aware that, that is something that they're exploring, and we want, we're glad to be at the table to support them in those endeavors. There was an aspect of that Bipartisan Safer Communities Act that actually included some expansion fundings for the pediatric mental health care access programs. So we did get that, we pursued that and received it. And we're going to speak a little bit to something that we're doing within that project related to emergency departments, if we can get to that. But great question. And we do hope to see some impact of that for our system. If you can just go to the next slide, there are several slides in here that are showing some outcome measures from the Child Adolescent Needs and Strengths tool that we use within Success Beyond 6. This is one way that we have an ability now to see how are students doing who are referred for those supports at the beginning of the school year and towards the end of the school year, and where are the impacts happening, and where might there be particular needs that could drive decisions around supporting certain evidence-based practices, for example. I was going to go into some detail with these. I think we'll skip these. Glad to answer questions as you look through those. If you could go to slide 20, Project Aware. This is a 5-year grant with SAMHSA that is through Agency of Education in partnership with Department of Mental Health. It's ending September of 2023. We do anticipate that there will probably be another funding opportunity coming up, which we would be interested in exploring. This really was about strengthening mental health supports within the multi-tier systems of support. So we have this interconnected systems framework that we've been training 3 particular school districts and there's identified schools in. Those are in Greater Rutland, Slate Valley, and then Orleans Southwest. And part of the, I think, success of what we've been trying here is the schools who have been involved in this project have implemented universal screening tools for measuring student social, emotional, behavioral needs and strengths. Lessons learned about the implementation process, but that has been an ability for schools to really get a pulse on how our students doing. And then we've partnered with different entities, including like Centers for Health and Learning, to provide training around suicide prevention and making sure schools have protocols in place for when there's an identified need, how do you refer and go forward with that. It's also really driving continued collaboration between Agency of Education and Department of Mental Health.
Right.
There's a quick slide on the next one with some of those examples of particular schools doing, none and then some screening, and then the significant increase once they started to implement that. But we'll keep going. I wanted to share a little bit of an update around mobile response pilot in Rutland. And thank you for supporting funding for this pilot in the past. First, I thought it'd be helpful for those of you who aren't as familiar to say, what is mobile response and stabilization service? It is for children, youth, and families, and it's really meant to be a families to call. Based on the family-defined crisis, there's a concept of you just go. It's not about triaging, is this someone who might need to be screened for inpatient or not? It's just responding to a family who said, we need some help. We had data and presented to this committee before about the positive outcomes that other states were seeing with this. So there has been a pilot in place. You can go to the next slide. In Rutland, they began direct services in October of, I want to say that's wrong. I think it's 2021.
Yeah.
Well, I know it was funded, but it took a while to get up and running.
It did. But that's the wrong date. It's October 2021, even looking at when people were hired down below.
Okay.
So my apologies on that.
No worries.
They have had challenges filling some of their positions. They were funded for about 7 FTE. They have filled about half of those, so they have more limited teams to be able to go out and respond. And then their time availability is what you see here. It's basically during the workday, although they can adjust and flex to families' needs. One thing that we've learned through this process, actually, you can go to the next slide. Quite a few families, about 62% of families who have called and talked to the mobile response team have asked that mobile response coming out to them happen at a later time, that it's not immediate, but it's later that day because of their own family needs. And so the ability of the team to kind of adapt and provide that has been great. This shows some of the data about how many calls have come in and that resulted in the mobile response, and then what were their needs, where was it provided, primarily in the youth's home, but some in school settings, and that majority of them, about 80%, needed some continued follow-up support and stabilization services. And one of the challenges here is this is meant to be short-term, and the challenge of kind of where to connect some of those families with next. What Rutland Mental Health experienced is that some families who were calling had never been known to their agency before. So this was reaching families who hadn't made that connection before, which was great.
That's great. Joe?
I had a question regarding the, 8 to 4:30, Monday through Friday. Is that just a staffing issue?
Yes.
And what would happen if someone was to call outside those times? Does it route them to another number?
Yes, great question. It routes it to the Rutland Mental Health Emergency Services team. And that team will say, would you like an emergency services worker, or do you want to schedule a time for mobile response to come the next day? And that's often how it happens.
And if you were to get that full 7, would it be 24/7? Like what in your ideal world, this?
That was the intent, was to have a team available 24/7. I think with a little bit more limited time on the weekends, just looking at what some other similar populated states had done. Experience in staffing.
Thank you.
Mm-hmm. Okay, should we stop?
Can I just a little bit? It's running. How much longer is this running?
It goes through June.
Goes through June. Okay, and this is the same or different from the RFPs that are now out? Because I think that is mobile crisis.
Correct.
So can you just touch on the difference?
Yes. So this is specific to children, youth, and families. And the mobile crisis RFP that went out and is still in process was in response to a new federal Medicaid program that is an available option for states to add to state plans. And that new federal Medicaid covered service has some really defined requirements within it around a 2-person team available 24/7, that it's to address the age span, the full age span, and address not just mental health, but substance use concerns, that it's a multidisciplinary team, but this has been as well. We've actually had a peer on this team, which has been really
great.
terrific. There are some other components to that. So mobile response and stabilization service could be a part of mobile crisis as part of that, child, youth, and family response. But as it is currently, would not meet the criteria for that federal new Medicaid.
Okay. And so is there any discussion based on the results you're seeing to try to expand this into other areas in the state, this specific one?
I think we would like to see some of the concepts within this available across the state, yes.
Thank you.
Next slide.
Just one quick question on this. So the pilot ends when?
The end of June this year.
They're not gonna end this, are they, or could they?
That's still a discussion that we're in process with. We'd like it to not end, but we need to identify.
I wonder if that was part of the staffing problem.
I can't speak to that.
Yeah, I know. I'm
mental health would be able to speak to that. I know what they've shared with us is lack of applicants, some of those who have come not showing for interviews, and even when they've made offers, a few of them have not been able to solidify housing and other things. This next slide, you may have seen already. It's about the trend of youth waiting in emergency departments with mental health concerns using the data that Department of Mental Health has access to, which is different than what FAHS, Vermont Association of Hospital and Healthcare Services, has access to.
Is this only involuntary?
This is involuntary all youth, voluntary Medicaid only youth.
Okay.
So it is trending down. We do typically see drops in the summertime, which you can see in the kind of July, August, and then trending back up. But this is something that we look at regularly and track. The next slide shows what are some of those activities that we've been involved with to try to address, specifically youth and their families who are waiting in emergency departments. The state interagency team, part of that Act 264 created body, worked with the Vermont Federation of Families for Children's Mental Health and created this brochure that you see on the left that's given it. We distribute it to all the emergency departments and they can hand it out to families. Vermont Program for Quality in Healthcare, we partnered with them also as well as VAHS in creating these youth activity kits that were distributed. The brochure is included in that. And then as part of our new HRSA project, we have an initiative with those expansion dollars that we were just awarded to provide some additional training for emergency departments. Do you want to speak briefly to that?
Yeah, sure. I mean, I would say you've probably heard the upstream and downstream approaches that are needed many times, right? And so there's a prevention-based lens, a lot of what we're talking about addressing like the deficiencies in the mental system of care, but then also how do we improve the care of support that the kids who actually find themselves stuck in emergency departments. So we really need to ensure that our emergency department providers are equipped with the knowledge and tools and resources they need to provide that high level of care. And one of the ways to do that is to create a trauma-informed, trauma-responsive environment. And so recently at UVM, there was a grant-funded project, a training program that was delivered to the majority of emergency department, like ancillary staff, so nurses, EMTs, mental health technicians, and in-person trainings were provided. And so I was sort of part of the advisory team there. And as we had an opportunity to pursue these expansion funds, we realized, why don't we do this statewide with these funds? And so it's a really exciting project that's just getting off the ground right now. It's 2 trainers with clinically trained experts in trauma responsive care, and then 1 peer support specialist who has lived experience in Vermont system of care, both as a child and an adult, and boarding in emergency rooms. It's going to be a 4-part module, so like 4 30 to 45-minute modules delivered up to 2 times in one day to hit as many staff as possible. And it's 4 modules: trauma responsive care 101, kind of reframing people to think rather than what is wrong with you, what happened to you. Verbal de-escalation 101, secondary traumatic stress, and strategies for reducing traumatic stress in children with a particular focus on those awaiting placements in emergency departments. So that is, the team is established and that's getting off the ground very soon.
Great.
The last two are about residential treatment and just what our process is. We can come back and speak to this if the committee would like, or I can go through this.
Let's take a couple minutes and go through it.
So this is where what I talked about earlier, EPSCT, the Medicaid benefit for children. Residential treatment is a component of our state plan, and so that is something that children who have that need and is determined to be medically necessary can access. And different departments have responsibility for that. So DMH is responsible for the need when it's around mental health and the child is not in custody of the state. DCF, Family Services, is involved for children in state's custody, and then Developmental Disability Services for those who have a developmental disability need. There are different costs related to residential treatment, residential care. There's treatment costs, which are covered by Medicaid. There's educational costs covered by education. If they are placed through one of our state departments, they're considered state placed by Agency of Education policy, and therefore Agency of Education covers those costs. Local schools and the special ed process has a parallel different process for accessing residential care through the education system. So those are kind of different. And then the room and board costs, which are state general fund from the department who's doing the primary funding. The next slide is from a quarterly report that we put out to the local interagency team so that they're aware of trends that are happening both from their regions as well as statewide. And this is really, I might need to zoom in, but it's showing those three different placement authorizing departments and where the number of children who have been funded in in-state and out-of-state residential care settings over the years, and then what were the presenting needs of those children. I do want to give a quick nod to say that two things. The capacity in Vermont has been more limited lately. We have had some programs close, but even those who are currently open have had more limited bed capacity than they're licensed for due to staffing. So they're running at about 61% capacity currently. And then we have some funds identified through the Home and Community Services Enhanced FMAP funding that you've probably heard about that we're working with other parts of Agency of Digital Services to look at putting out an RFP for a database to help us with this type of tracking, because right now we're doing it through spreadsheets for these three departments and want to be able to track it more effectively. So I just wanted to mention that as well, but glad to answer any other questions related to residential. That would be helpful.
I have just a couple of questions. So if a youth, if it's medically necessary for a youth to be placed in residential treatment and they have commercial insurance, what happens?
There is parity, right? So if typically the determination of medical necessity, often there's a provider already working with that youth and family. And so they would need to contact the commercial carrier and work with them around identifying what are the options. Some commercial carriers have a care coordinator that they can work with, or families can also call, and the providers can support families in doing that. Some families have both, with commercial as primary and Medicaid as secondary. In that instance, the commercial is still the primary lead, and then Medicaid is secondary to that. So our Department of Mental Health, our care managers would be contacted, and if there was a need for the Medicaid component to kick in, so to speak, then we would go through our typical process as if it were a youth who didn't have the commercial, once that commercial component has been exhausted.
It's been exhausted. And I'm assuming there's a process that the treatment centers have to go through for DMH to recognize them as an appropriate sending place.
So they have to be Vermont enrolled Medicaid providers, just as any provider would have to. So that's through Department of Vermont Health Access. And then they need to have a contractual agreement with the state And we have worked with Department for Children and Families to, as best we can, have those agreements speak to the other departments so that we don't have multiple agreements to the same program.
Great, thank you. And then I want to make sure we have enough time, but I do want to make a comment, and this is born out of frustration that I feel that in our state, we are not recognizing the lack of funding that we're putting into some of our programs. This is not what I'm about to say a reflection on anything here, because this is amazing. But the thing that stands out to me is that a lot of our work you've presented here is through grant funding and not state funding. And so where would we be if we didn't have these grants? And we're already in a world of hurt. So I don't know if this is possible, and I don't want you to do a lot of work on this, but if you can do a quick snapshot of what's grant funded, like not programs, but just how much we're getting from grants and how much we're putting in on state dollars to serve our youth and adults. Yeah, would be really helpful.
And that's possibly partly on me, wanting to highlight some of the initiatives.
Which is great, yes.
And certainly can speak to how the base budget and what that looks like. We do have our annual statistical report that shows what the designated mental health agencies have been providing for services.
Great, so if you can just send that would be fabulous. And everything you're doing is great, but there's still, with all of this, there's still such a need. And I'm just trying to amplify that need in this building as we work this year.
Thank you. Thank you for your attention to it.
All right, we'll do one last question and then we're gonna.
Yeah, just a question on this slide quickly, I guess. The graph to the right, those, a child might have several of those.
Yes.
I assume. Okay.
Yes, thank you for recognizing that. Yes,
Yeah.
and often do. Yes.
Thank you.
Thank you both for your work. We appreciate it. All right, Linda and Tom, come on up, or whoever's coming first, come together. Somehow we now have 3 chairs when we've been short chairs all week. So take the comfortable ones and let's move the other ones out of the way.
I'm going to start and
Great.
turn it over to Linda. My name is Tom Hubner. I know a couple of you. I was the CEO of Rutland Regional Medical Center for a very, very long time. I've been working in healthcare in Vermont since 1990 and healthcare for 45 years. I retired 5 years ago. I'm now, believe it or not, kind of. I am now on 5 boards, all of them healthcare related, trying to give back and all on volunteer basis. By far the most time consuming is the Barbara Retreat. It's not bad.
Linda's like, great.
I was asked several years ago to go on the retreat board, and I said yes immediately, because as a community hospital person, I understood the critical role the retreat played, and frankly, how fragile it is. About a year ago, I became board chair. And I want to go back to a year ago and introduce where we've come, frankly, through Linda's leadership over that year. We were in bad shape a year ago. Our census was 45. We've been usually seeing 100 acute inpatients a day, all the time. Staffing was an issue. We're underfunded. We're losing money by the bucket load. Morale was not great. Things were not good. We were leaving patients backed up into emergency rooms, as you've heard. And we need to make some changes and get to a different place. We have, over the last year, through 2 really important partners. First has been the Agency of Human Services, Department of Mental Health, but also DEVA, who played a critical role because they gave us a changed way of reimbursing us that allowed us to rebuild staff, because staffing was the underpinning of our issues. And that was critical to moving forward. The other was Linda and her team. Linda came in as CEO right at the end of March last year, early April, I guess, and has turned the place around. I said we were at a 45 census at that point. We said we wanted to be back at 75 by the end of the calendar year. We're over 80. We need to be back at 100 by the end of June for two reasons. One is the rest of the system needs us. We are the only provider of acute services to child and adolescents. We provide 50% of the adult acute services. We are critical to the system. Without us, everything doesn't go very well and wasn't going very well. I also need to say that if we are not at about 100, we are not financially sustainable. Hospitals have large overhead. Scale matters. You can't do a small unit, a small unit, a small unit, a small unit, they fall apart. Unless they're part of something much bigger. And I ran sites in Rutland for a long time. The retreat needs to be around 100, plus we do outpatient, plus we do residential, but at the core is our acute services. So we need to be back at 100 and providing those services. And we've come so far. We are confident we can get all the way there, but there are risks out there, as you might imagine, along the way. So with that introduction, I'm going to turn to Linda to tell about the journey a little bit more and where we're heading now. And then both of us are happy to answer questions.
Great, thank you.
Thanks for having us. So as Tom mentioned, a year ago this month, we had 45 beds operating. And of course, the pandemic just really did a job on the retreat. We have a congregate setting for our patient care, so patients are mingling. They don't stay in their room. And so when you have a COVID outbreak, it's pretty devastating. So we needed to grow the census. And of course, the way to do that was to hire the staff. And, we heard from our, colleagues at UVM and how hard it is to hire staff, just especially psychiatric staff. That was a really big challenge. Thankfully, working with the Department of Mental Health, we were given resources to bring in travelers. Not the ideal situation, but it was a way to open capacity. The EDs were really feeling a lot of pressure because, the retreat's ability to take transfers had been dramatically impacted. So we got those funds in the first quarter of 2022, and we have since had to rely on travelers. Right now, we have about 100 travelers in-house. It runs between 50 and 60% of our direct patient care staff. And that is brutal. It's very difficult to have resources coming in for 13-week assignments. The impact it has on the employees to train those folks, work with people you never saw before, and show up one day. So, the whole traveler piece, which has allowed us to improve capacity, but it has a lot of challenges with it. We're seeing a little bit of improvement on some of the positions, but that was a big obstacle. So right now we have 85 staffed beds. We're opening another 5 adolescent beds February 1st. So that'll take us up to 90 beds, and we will have 10 additional beds because I have more travelers coming. We'll have another 10. So we will hit that 100, I think, in the next 60 days. Now, having 100 staffed beds is not the same as having 100 filled beds, right? And we can't afford to have beds that are not filled because we have all the labor cost, and that is what runs the biggest expense at the retreat is labor. So if we have travelers in-house, we need to keep them busy. So those referrals are critical so we can have those beds occupied and have revenue coming in. We've been doing a lot of work juggling around units. We did something this year that was a little different. We created a swing unit, and that unit was changed from adult care to youth care as the demand in the EDs was shifted. So the thing about youth care is when summer comes or when holidays come and school is closed, referrals drop. And so you've staffed for those beds, and I learned that the hard way this summer, when all of a sudden our demand dropped for youth services probably down to 60%. So I had all the staff And I couldn't let them, sit around, so we shifted where the need has been. As Tom mentioned, we're the only provider of inpatient youth services, and that's children, which are age 6 to 12, and then 12 to 18 are adolescents. We support 50% of the adult needs in the state of Vermont, and we're the largest provider of level 1 services in Vermont. We also service Massachusetts and New Hampshire on a limited basis. New Hampshire, almost every day has referrals for us. They like the care at the retreat, but if we accept a New Hampshire kid or adult, that ties up that bed for an average of 17, 18 days. So every day we face the choice of, we have an empty bed, we look at what Vermont may have, and if there are no Vermont referrals, which has been the case in the past several weeks for adolescents, we have to choose if we want to bring in a New Hampshire kid and tie up that bed or leave it empty. So every day, I'm intimately involved with our admissions team, looking at those admissions and trying to juggle. We certainly give Vermont priority. Our payer mix is 85% Medicaid and Medicare. And we have some charitable care. So we have very little commercial business, relatively speaking, very different than acute care hospitals.
I would add that Medicare is our worst payer.
Right. And that's 30%. So 55% roughly is Medicaid, and 30% is Medicare. And some of it does convert to Medicaid, but Medicare is a terrible payer. And we lose money with every Medicare admission we take. So we have been working, to optimize space, to have this swing unit. Last night I was at a hospital association meeting, and the CEOs were thanking Retreat for having swing space. It's been very helpful for them that a bed's not all the beds are, exclusively designated for one population. We're shifting. It drives my staff crazy because it's not easy to convert a pediatric service to an adult service and vice versa. But, it's something we need to do. The other obstacle that we were facing was transportation. Of course, we're at the bottom of the state, and we get referrals from the whole state of Vermont. So we spent quite a few months doing analytics and looking at what the impact was on transportation. So we'll get referrals, and we can't get the patient to the retreat. So we felt we needed to fix that, and we have entered into a contract with Rescue Inc. to have an ambulance available Monday through Friday, noon to 8 p.m., which is when the brunt of the referrals are made. So it's a pilot program for 1 year. It starts next week.
And anywhere they'll go in the state?
Anywhere.
In Vermont.
Yeah,
In Vermont, right.
Vermont. They can't cross state lines, right? So anywhere in Vermont. So we're really happy to have that opportunity. And, they're in Brattleboro, so they're right around the corner from us. In terms of, the competencies that the retreat has, I think what differentiates us from perhaps the care that is delivered in acute care hospitals is that we have a multidisciplinary care team that's comprised of psychiatrists, psychiatric nurses, psychiatric advanced nurse practitioners. We have occupational therapists that are geared toward activities for youth and for all patients, but also for youth. We do have social workers, and so we have this multidisciplinary team and we have a medical team. We have a group of advanced nurse practitioners and a medical physician. So we're able to treat medical issues that come in. So this enables us to do 12 hours of programming a day for our patients. So they are not, it's not just the psychiatric piece that's, the doctor or the therapist that they see. They have activities all day, things like music therapy, journaling, movement, recreational activities. We have outdoor activities, indoor activities. Especially with youth, they need to be busy all of the time that they're an inpatient. So our competencies allow us to have that broad array of therapeutic treatments for the patients, to teach them coping skills, to help them with self-care so that when they're discharged, they can, be in a better place and hopefully not have to return. Another obstacle that we continue to struggle with, and one of the things that has been affecting the census in an adverse way, is the fact that we have not had a place to discharge youth patients. And we had an adolescent residential program that closed during the pandemic. We are looking, and I talked to Commissioner Hawes about reopening adolescent residential. So we currently have a child residential program. We have 8 beds for kids 6 to 12, but we have nothing right now for 12 to 18. And we've had to keep kids on the inpatient, floor units because we had nowhere to discharge them. So we're looking to open an adolescent program in 2023, and we're hoping we can get 12 to 14 beds. So that's something that we're working on.
So Linda, can I just stop you there really quick? Can you explain what the difference is in the level of care for the retreat versus a residential program?
Yep. So the inpatient services, it's really intensive care for mental health services. It's a locked unit. Many of the patients, particularly the youth, are there because they're trying to self-harm. It has to be a very safe setting so that they don't elope from the facility. Residential, there's a couple levels. The one we're looking at is a psychiatric residential, so that it's a safe and protected environment, but they go out.
Okay.
They go on various activities. They come on the campus. They spend time outside. There's more freedom, but there is a psychiatric therapeutic piece to it. And then there's residential where it's not locked and they stay there. It's their place for until they're better.
If I could just add too, on the hospital side, the 100 beds, I mean, those are acute hospital level care.
Yep.
There are admission criteria set by different payers for what that entails and what level of need. They have to have daily active service on a whole variety of fronts. Residential tends to be, okay, you're now stable, relatively speaking,
Right.
but still need a bunch of support.
Okay.
But it is a step down from
From the
acute.
acute care before they're
Yeah.
able to go home. And with the child residential program, is that right on the retreat grounds?
It will be, yes,
Okay,
on campus.
okay, great.
And we also have to educate the kids, and while they're
I was gonna ask that
or
too.
while they're residents, yeah. So we have services that come in. We used to run our own school, and we closed that during the pandemic, and that's not our area of expertise. So we do contract with teachers to come on campus and come into the hospital setting so that these kids still get their education while they're patient.
Do you mind if we ask a couple other questions, or do you want to finish?
No, that's okay.
Okay, I'm gonna go Topper, Daisy, and then Leslie.
Thanks for what you're doing.
Thank you.
My first question is, you say you're having trouble filling the beds. We here in this room hear about how the emergency rooms are backed up. You mentioned one thing, that you can't get the kids there, and you're gonna have an ambulance. Is that the reason why you can't increase the census?
No, we have the staff to increase the census.
Right.
So the demand for services goes up and down with youth. And it's very consistent with the school year. So in the summer, the demand for services doesn't exist. So we can't fill those youth beds. In fact, we're trying to figure out a summer program that has a therapeutic component to it. But then when you get to January, there's not enough capacity. There's so much demand in January, February, March, typically, that, the retreat will have 30 youth beds and they can get filled, all 30 of them.
Are you filling now?
Are we filling, well, right now we have 20 and they're probably all full today. I didn't get the census today. So we have 82 patients today. We're staffed for 85 beds. Of course, we have patients coming and going all day, discharge, admission. So when, you're not usually 100%.
And some of the, if I could just add to that, some of the story about backup in the ED, stories last longer than reality sometimes. A year ago, going back to that moment, that was we were contributing to that because we didn't have the beds open. That's no longer the case. We still have some more we want to open, as Linda told you.
I'm sorry, keep going.
So some of that continues. There are still moments where every bed is full across the state. And that's why we want to get those last ones open. But it's also why it's so important to have discharges happening. The acute side is the most expensive, as you can understand, I'm sure. Having people in acute beds who don't need them is not the best use of resources. So that is part of the answer as well. Transportation's the other one, though.
So the flow just isn't going.
And we're hearing, though, that there aren't beds available to get the kids out of the hospital.
And that is far less true than it was a few months back.
But there is also still the need in that there are children who cannot go to the Brattleboro retreat because of co-occurring medical situations. Yeah. That is what the hospital and Department of Mental Health has testified to.
So there was one notorious case last year, which ultimately we did take after Linda became CEO. The retreat turned down for quite a while. Ultimately, that kid did come to us, and we did find a permanent, longer-term piece for that. But we have changed our staffing so we can take the vast majority of those patients. We're committed to adding more resources should it become necessary to accommodate every kid who could benefit from our care.
Yeah, we have many kids that have co-occurring medical. That's why we have a medical team. And we've had a medical team for as long as I've been there. And I've been with the retreat for almost 5 years. So, and I have been in communications with the CEO of Brattleboro Memorial. And we have been talking for months
Who's
about.
Also fairly new.
Right, he's new. We came the same. He came in May, I came in April into this role. And we've been talking about Brattleboro Memorial providing primary care medical services at the retreat or some other method. And we've been, in those communications because we recognize, that that's part of the healing process is looking at the total condition of the patient. So I have 100% guarantee by BMH, which is a mile away from the retreat, that they are there for us. This is different than how it was before with the prior leader that was there. The retreat isn't just inpatient care, and I think this is important to point out. We have inpatient care. We also provide outpatient services, outpatient therapy, some specifically for youth. We're looking at a partial hospitalization and an intensive outpatient program for youth. We have space for that that's newly renovated. We're looking at the residential services. We're looking at opening an LGBTQ unit for youth. So we're trying to have a full continuum. Our mission is to support all of Vermonters who need mental health services, but our passion is to support children and adolescents. And we're expanding our services where we can and building partnerships.
So I'm sorry, we have quite a few questions and I just want to make a comment to this discussion. So I appreciate everything I'm hearing and it does sound like, the Brattleboro retreat has definitely taken a turn under your leadership. So I thank you. We are hearing a different story from other providers in the healthcare system in regards to children waiting and where they can go in the need. So I just want to be clear that we'll get to the bottom of that, but we are hearing a different story.
Yeah, and I think there could be days when we are full and they will be, the kids will be waiting. We're doing a lot of work on the admission side to get that flow through better. We've I think we've solved, or we've improved, I'm not sure we've solved, we've improved the transportation issue.
Yes, which is great.
And if we can get discharges happening, because we get, kids that are bottlenecked in there.
Right.
So this is holding up capacity. And there's no, beds are not purchased. No one has purchased beds. So when they're empty, we have a choice to make. And if we have referrals coming in from another place, then we have to
Oh, absolutely.
think about what do we do? So that could end up, those decisions could end up filling a bed. So, I guess what I would say is, we're working to collaborate with and partner. We've had a strong partnership with DMH. We've had a strong partnership with AHS. Without those partnerships, I wouldn't be sitting here today because the retreat wouldn't have survived. So that's been wonderful. We want to serve all of the people of Vermont that need services. And, should the project in Bennington not work out and that RFP is reissued, we hope that we'd have an opportunity to submit a proposal so that we can strengthen what our services are and expand what our services are.
Just going back to the hospitals for a moment, one of the things we've begun doing is, actually Eric, who's doing it, is we are now calling on all the hospitals and particularly the EDs, and understanding their barriers, what we, and Linda, including last night with all the hospital CEOs in the state of Vermont, has said, you have a problem, call my cell directly, and we will take care of it. That doesn't mean there's 100, is there days that every bed is full? No. Yes, there are. But we really want to not be that problem. We're not going to solve the patients who are backed up waiting for a nursing home bed.
Oh, no. If you could, that'd be great.
Yeah, but that's not going to be us. But we want to solve every one of those problems that we possibly can. And it really has been her leadership, Linda's leadership, that has made that such a huge improvement. Is there work to still be done? Of course, there's always work to be done. And we are really intent upon doing it with strong support from a very good board, I might add.
I'm sure it's a fantastic board, especially the chair.
No, that was not where I was going. We have psychiatrists on the board. We have people who've run healthcare organizations on the board. We have local community people on the board who are very dedicated to supporting the leadership of the retreat. I need to also make one other point. A few years ago, we were also having difficulties with labor relations.
Yes, I do remember that.
Turned around entirely. And Linda came out of the HR COO role and had great relationships with the unions. And there were literally no grievances. They are partnering with us to make sure the beds are open and patients are coming through, which is a huge turnaround from a few years.
It is great news all around. So everyone has questions. So I'm going back to Topper.
This is a fairly easy one. You talked about the resources that you're getting from the Department of Mental Health. Help pay for those travelers.
At the beginning, yes.
Are those resources infinitum?
Are those resources what?
Are they ever going to stop?
They did.
They did stop.
Yes.
So you're paying for the travel?
No, replaced.
Yeah. We got specific funding for travelers to jumpstart us when we were at the 44, 45 level. Now we have negotiated a rate of reimbursement that is enabling us to continue to fund travelers. So it's continuing in a different way.
Yeah, so we negotiated, it was effective July 1, calling an APM, it's an alternative payment method from DEVA, which gives us sufficient resources so we can afford travelers to open the beds. So at first it was direct money, now it's reimbursement rate. So we're at risk for it now, but the rate allows us to make that investment.
Yeah.
Thank you.
Okay. Daisy.
Hi, Tom and Linda. I'm behind you online. Sorry.
Sorry. Sick.
Good to see you both. I have a couple questions. Just number one is about which.
You might need to turn off your video. You might need to turn off your video. You're going in and out a little bit.
Okay.
Oh. there we go. Thank you.
Okay, let me try again. My first question is about which units are closed now. Did you close Linden and one of the Tyler units during the COVID pandemic?
Tyler 1.
We did close Tyler 1 at the request of the state. Tyler 1 was a substance abuse disorder unit. We had about 22 beds. That was closed for the entire time. That's the unit that we're now using as a swing unit, but not with 22 patients, probably 7, 8 patients.
Linden Lodge has stayed open.
Linden Lodge has been open the entire time.
Is that the one across the street?
Yes, it's in that Linden building, yeah.
Sorry, go ahead, Daisy.
And so your still target census is 100.
Yes, the average. So that means sometimes in the year we got to be over 100 because there are seasonal dips that happen with referrals that drop it down. So we got to average out at 100 for the year to break even financially.
Got it. And then my next question is around your intake and discharge processes on weekends. I am thrilled to hear that you have that contract for transportation. Absolutely thrilled. And I just wonder if that is also going to cover weekends and if staffing aligns with that for you all.
We do take admissions on the weekends and we do discharge on the weekends, but we don't have transportation at this time. We want to see how this works out. I mean, that's not to say we can't add transportation. I mean, the retreat is paying for this project and it's not cheap. So I think if this works and the hospitals use it, then we could consider expanding it. I do want to mention, I did forget to mention that we just launched a telehealth project with Rutland for child and adolescent patients, the ED.
Great. And have offered to do it with Bennington.
Yes, I did talk with Tom D and offer it for him as well as transportation services.
Great.
So we would do that with any ED that doesn't have any psychiatric, medical staff.
Great. Okay, I think it was, I don't know who was next. Art. Lost track. Leslie, Joe, Ellen.
On the issue of transportation, parents don't transport their kids down? I mean, how?
Not always, no.
Yeah, I mean.
Their jobs get in there's jobs, there's all sorts of situations.
I mean, this is a child that's in the ED.
Right, correct.
They're in a high acuity state. And it's best that a trained professionals, transport them.
Okay, all right.
Yeah.
The other question I had was around, you mentioned you have no place to discharge, you're looking for a place to discharge adolescents.
Yep.
Is that what, okay.
Yeah.
Explain what, I don't get that in terms of if they're done with their treatment at your place.
Well, inpatient treatment is very intense and it's very confined, right? Because they're in a hospital setting and it's a locked setting and they've gotten better and they don't need that kind of, supervision or intense medical treatment. So by transitioning them to residential, it's a lower level of care before they go home. So it's just a way, it's the continuum. And then they might go to, outpatient therapy once a week or something.
Can you send them home?
So, we send many home. Some are good,
But not everybody.
yeah, but not everyone.
Okay.
And they sit there in the ED, in our inpatient, and they can be stuck there for, a couple extra weeks, which is frustrating for them.
Right, I'm sure.
And everybody. So, yeah, I think,
what do you require to have them walk out the door? Do you require them to give you an address where they're going to go, or are they waiting to find a place?
I'm sure that the social workers have,
All right. Okay.
So every hospital
Yeah.
has a requirement to have a complete discharge plan before any discharge can occur. And it has to be safe and appropriate for the clinical setting or clinical needs of that patient.
Gotcha.
And that's true of a med-surg patient as well as a psychiatric patient.
Leslie?
So I'm curious about your staffing, and you talk about this huge amount of travelers. I don't necessarily understand the training of the travelers in the psychiatric world. How does that fit in with your staff model?
Well, we look for travelers that have worked in psychiatric facilities. We can't always get that, but that's our, first thing we do. All travelers come in, so if we bring a nurse in or we bring in a tech, they go through a 2-week orientation, which is training on, trauma-based care, a lot of, different interventions that they would use with patients, and how we do things at the retreat. And then they go out to the units where they're precepted by our staff. And right now, we're looking at having dedicated preceptors. So all these things add people. So we're looking for dedicated preceptors, that's all they'll do, so that everyone gets consistent training. And they stay on those units. They don't get redeployed someplace else until they're ready. I mean, we've had travelers that have extended up to a year. So they'll just keep renewing and renewing. So they're very competent at that point. But it's challenging. We invest a lot up front, and that's, while they're in training, we're paying those fees.
Yeah.
And it's expensive.
I feel worried about this just because, psychiatric is a specialty.
Every day.
Oh, yeah.
Yeah.
Even with people who are coming away with psychiatric backgrounds, they don't know us. We don't really know them. Travelers is not the best answer. One of the things I've said before is the only thing worse than a traveler is not having a traveler when you need one.
Yeah.
It is not optimal, and we would love to get out of it. But every healthcare organization in the country is struggling with this, and there's great competition and shortage for these people. We've actually done better. You want to just mention what we've done around housing, because that's
Yeah. So of course, there's not a lot of housing in the Brattleboro area for all these travelers. So with some help from AHS, we were able to take the houses that are on Linden Street, if you're familiar with, and convert that to traveler housing. So we actually have 18 rooms that we rent to the travelers. So we're a landlord as well. And we have been working on, we actually signed a memorandum of agreement with a group in Brattleboro. There's an empty nursing home called Holton Home that during the pandemic, Bradley House that owned that had to put all their patients in one facility, and they are having dire financial challenges by having a whole facility. It's 35 rooms in there. And so we agreed to rent that facility, lease it for the next 3 years. That was supposed to go before the Vermont Housing Conservation Commission today, but it didn't make it on the agenda. There is an encumbrance in the deed we just discovered that says that property can only be used for low-income housing.
Yeah.
So the board is kind of torn in terms of, they talked about it today, we were listening in. So they've deferred this to a special committee because they said there are public good factors here, both the nursing home and their financial issues and our need for housing. We brought in 35 travelers because we thought we brought 38 in actually because we thought we had those 35 rooms February 1st. So now we're scrambling. And the snow isn't helping.
No, I'm sure it's
All the
not.
skiers are coming to Vermont. So I don't know where that's gonna go. I think they're struggling. It's hard to choose between staffing a hospital, saving a nursing home, and the need for low-income housing. So I don't know.
No, good
what'll
choices.
happen. Yeah.
Alan and then Joe.
Okay, yeah, you were talking there that regardless what happens in Bennington, you had some proposals and ideas or plans. Can you share some of those with us?
Well, if the RFP is reissued, if Bennington doesn't move forward, Southwestern Medical Center,
Right.
The retreat would hope that we would be eligible to submit a proposal. I mean, I have some ideas. This would have to go to the board. I think we can do more in the state. To me, we're the hub of expertise in inpatient psychiatric care for children and adolescents. And it would be an honor and to be able to move forward with more services in an expanded way. So that would depend where that project goes.
Joe?
I feel like you partially answered my question, because my question was regarding travelers. But the additional piece to that question is we've heard from so many people who have come in and testified about, as you said, the only worse thing than a traveler is not having a traveler. And yet, as you have testified just now, it creates many problems for the system in training and being much more expensive and now having to be a landlord and all these things. So how do you see, do you have a plan, or even if it's not an official plan, is some idea of how you could see moving away from travelers over time and bring it back to what the levels of travelers were pre-pandemic? And what does that look like for you?
Well, I can't impact the labor market, and it's improved a little bit, but it's never been the same since the pandemic. I mean, certainly wages play a role there. Our wages are competitive. I just looked at them a couple of weeks ago. We're competitive with Massachusetts. As a bordering community, we always have Massachusetts wage pressures, but we're okay. And I'm actually not hearing anything from the union. We did a 25% increase about a year ago, and we were ahead of the market. So now we're at the market. I was talking to my CEO colleagues last evening. I said, we need to get together and start our own travel agency for Vermont. And I'm serious about that. I mean, my challenge is we're unionized. I'm not sure I can't do it. But I discovered last week, because we changed the schedule for the travelers from 3 12-hour days to 6 6-hour days while they're in training, so they could see what it's like on the weekends. And a number of them said, oh, I have plans. And we're like, well, what do you mean you have plans? Well, I live 2 hours away. I'm thinking, what hospital just lost somebody to be a traveler? Because they are living in Vermont and they've taken these travel assignments. So we need to find a way to shut that down, in my opinion. And all of us need all of the staff we can get that are in the state. And could we, through maybe VAS, the Hospital Association, run a staffing function? So if you want to be a traveler in Vermont, and there are many that want to, because they want to see what it's like here, they would have to go through this agency, and we, try to run our own travel agency.
And particularly for nurses, which is not the only issue, but it's the highest volume issue.
Yeah.
Two things I would add to that. One is we do not have enough educational pipeline.
Yeah.
And frankly, that's tied to not paying instructors enough to add capacity to the nursing schools. Some of that is a state issue, frankly. Second, being old and around, the things that's turned that around in prior cycles, sorry to say, was an economic downturn. Suddenly people come back into the workforce who were out of the workforce or find that profession because it is stable and provides a good livelihood, and people come back to it. One of the great positives that's happened in nursing over the last 10, 20 years now, far more men in the nursing profession, which has been a huge plus. Yeah. Tell your children, it's a good profession.
Yeah.
You can make a very decent living, and you do really important work. So we need to talk it up. I do think the traveler thing will dry up eventually, but until the entire economy slows down and inflation drops, we're not going to be at the head of that. This is a national issue, it's not a local.
Yeah, it's not. And we do need our federal partners to help us try and find a solution without a doubt. So I want to thank all of you. I will say we've done a lot of education in this committee the last couple of weeks, getting everyone up to speed, and it's been a bit depressing. And I feel like today we've heard some really good programs that are happening, really good collaboration that's happening. There's still a lot to do, but I appreciate the work, especially with what's happening at the retreat. It sounds like there's been a big turnaround. So thank you very much.
Linda started in April. And we had her on an interim basis. And at the end of September, we said, this woman is hitting it out of the park. And the entire board unanimously said, please, God, stay.
Right.
He said yes.
But, well, my team,
With your whole
staff, it's not me. It's not just me, believe me.
Well, thank you to your staff, all of us. Thank you.
Here, Eric
Thank
Rosenbauer.
you. We appreciate it. We're gonna call it a day. Thank you very much.